Good morning. I'm Jennifer Watkins from the Protocol and Validation team, and I'm excited to have the opportunity to speak with you this morning about internal data validation. So, our objectives for this session are to define internal data validation and quality data, identify internal data validation resources developed by NHSN, and describe recommended internal data validation activities. So my presentation kind of goes hand in hand with Scott's, so you may see a little bit of repetition between the two, but I try to take a little bit of a different tack to it. So the first thing we're going to do is start by defining internal data validation and quality data and discussing their importance. There are two types of data validation. The first one is internal data validation, and that is the active process of checking your own data to ensure quality. Internal data validation is generally built in as a routine process at the individual facility level. External validation involves medical chart reviews conducted by an external agency, such as the State Health Department or CMS. This process is more resource intensive and is intended to assess the accuracy of HAI data that's been reported to NHSN. Today, we're going to focus on internal data validation. So what do we mean by quality data? Quality data are data that are complete, timely, accurate, and consistent. And so why did I include a picture of Florence Nightingale in a presentation on data? Because in addition to her contributions to the nursing profession, she's also well known for her work in statistics and for using graphical representations of statistical data to implement medical and public health reforms that saved lives. So I kind of also look at her as one of the first infection preventionists. So why is quality data important? It's been touched on a little bit by our prior speakers, but I'm going to review it again. It helps you to assess whether your prevention efforts are effective. Also, the Health and Human Services uses NHSN data to measure progress towards the HII Action Plan 2020 targets for national HII reduction. It also allows you to benchmark your infection rates and progress against national data. And for those of you who aren't already aware, CDC just published our 2017 National and State HII Progress Report last week. So I recommend you take a look at that. It's got a lot of good information in it. It ensures that you are fulfilling your reporting requirements for state, CMS, and other entities. It gives you the confidence that your data will hold up if there is an external scrutiny from the State Health Department or CMS. And remember, routine internal data validation leads to high quality data. So by a show of hands, how many of you perform routine internal data validation at your facility? Very good. I'm glad to see that. Very glad to see that. So how does this internal data validation lead to quality data? Your routine internal data validation process identifies where the systematic weaknesses in data collection and reporting are and gives you ideas on how to correct them. It assures that the data reported by your facility are complete, timely, accurate, and consistent. In other words, they're quality data. It promotes coordination and partnership between stakeholders, and it helps build confidence in your own facility data. So, as you all know, the NHSN application has business rules built in to check to make sure that your data is sensible and reasonable. For example, you're all familiar with the data validation errors that come up if you're trying to enter implausible data or if you haven't completed your forms. And Scott spoke to you about the alerts, which inform you of incomplete and missing data. So with all these data checks built in place, why should you also validate your own data? And we had an excellent question from somebody earlier about that. We can't check to see if you've entered 3 instead of 300. And we can't check to see that you've actually collected all your data and made sure it made it into NHSN. So that's the reason that you need to make sure you check your own data. Validating data assures your stakeholders that your program is based on quality data. Remember, this is your data, and you may be surprised at what you find, especially for data being submitted electronically into NHSN. And we just, in our recent March 2019 newsletter, have an article in there about verifying the accuracy of your electronic data. So I recommend you take a look at that. Validating your data can be an intimidating task, so NHSN provides guidance for facilities to develop an annual plan for surveillance and data validation. We have an internal data validation and guidance toolkit, and that can be found on our data validation page. And the URL is located at the top of the slide. And we update this guidance annually. You can also access the NHSN data validation webpage by selecting data validation guidance from the left navigation bar. In addition to the internal validation guidance and toolkit on this webpage, we also have links to our external validation guidance and toolkit, which is what state health departments will use if they do an external validation for you. And we also provide NHSN resources for the corresponding year for the validation guidance. And this includes the patient safety component manual, procedure code mapping documents, the NHSN organism list, lab ID and VA calculators, training materials, and the NHSN HAI checklist. So if you're looking for resources from a prior year, you can usually find them on our data validation webpage. I'm also really excited to share with you that we're in the process of updating our data validation webpage. And this is a sneak preview of how it's going to look. And our new webpage and the 2019 internal validation guidance and toolkit will be posted soon, so look for them the next couple of weeks. The internal validation guidance document provides guidance and recommendations for data validation activities to ensure that data reported to NHSN are of high quality. Included in the document are our data quality survey tools that can be implemented to learn about your facility's current surveillance practices and identify needs for additional staff training. There is a separate survey for CAUTI and CLABSI, one for SSI and one for lab ID events. And we also have data quality checklists, which I'll go into later, for each HAI type that will provide you a list of metrics recommended by our NHSN SMEs for reviewing your data prior to its final submission. We suggest that the activities for data validation at your facility are grouped by their frequency. So in the following slides, I'll review the suggested activities for each time interval, annually, monthly, weekly, or daily, and as needed. So to start off, we recommend that facilities create an annual surveillance and data validation plan. Sometimes you'll include it in your ICRA, or you can have a self-standing plan that lists the frequency and types of data quality checks that you perform and identify the individuals responsible for the implementation. You'll also want to ensure that your program adheres to NHSN protocols, definitions, surveillance methods, and that was touched on earlier. You want to conduct a check of the adequacy of your facility infrastructures, including your ability for electronically reporting and collecting data, your ability to link these electronic systems, and the accuracy of the data that's obtained from these electronic sources. And accuracies in these elements are necessary for the consistency of your data. You want to make sure to review your facility descriptors, and if additional patient care locations were added, make sure that you map them correctly. You also want to recruit partners. IPs can't do complete surveillance and validation alone, so utilize your resources. Annually assess the knowledge and practices in your facility for data collection and identify gaps in training needs and address them as necessary. So Scott spoke about the annual facility survey, but I wanted to reemphasize the importance of verifying these data for teaching hospital status or medical school affiliation, the number of beds, and location mapping, since these data are used for facility risk adjustment for a lot of the HAIs. And incorrect data in these fields will impact your SIR. Additionally, you could administer these data quality survey tools that are included in internal validation guidance document. The surveys include some questions that assess your practices on numerator and denominator collection, and it also provides rationales for the correct answers to ensure that your staff understands the correct NHSN procedures and definitions. These surveys are helpful for your facility to learn about the current surveillance practices and also identify any gaps in knowledge and needs for training. And again, these surveys are available for CAUTI CLABSI, and one for SSI and one for lab ID events. So you can administer them to different people if you have different people collecting those data. For collapsing Cuddy denominators, you want to determine which denominator counting method is more appropriate for your facility, a daily manual count or a weekly sampling method. Some of the things that you want to look at: does your staff understand the definitions of central lines and indwelling urinary catheter and how to count them correctly? Are there situations where data are missing or implausible data has been reported, such as reporting more indwelling catheter days than patient days for the month? It's vital to keep a log of how frequently these errors occur and review these results with your staff to ensure that you have continued accuracy of your counts. We also recommend that once a year you check data collection practices and validate a few of your locations for a week or so to assess that you're continuing to get accurate counts for your denominators. When you're switching from a manual denominator counts to an electronic denominator data collection system, you need to be aware that electronic data are often inflated unless they're validated. Manual counts, which are defined as counting patient days and device days at the same time every day for each reporting location, are considered the gold standard for collecting this data. And this is the standard against which other denominator counting methods should be validated. NHSN requires every facility to validate their electronic denominator counts against manual counts for every reporting location until the electronic counts are within plus or minus 5% of the manual count for 3 consecutive months. And once a reporting location achieves this goal, then you can begin reporting the electronic counts for that location. But if there's a deviation for any month in a reporting location, you want to start your 3-month count over again so you can achieve that 3 consecutive months. And obviously, you're going to want to work with your IT department to correct any electronic counting problems that may be occurring. And we've included a denominator validation template in the internal validation guidance document that can assist you with this process. And this kind of validation only needs to be once when you first transition to the system. You don't have to do that every year. So recently we've had a lot of questions about people who are now transitioning to their second electronic system. And once again, if you're switching to a new electronic system, we also require the same validation process is used. Remember, your manual counts are your gold standard against which you should be validating your other denominator counting methods. So new electronic validation or new electronic counting system needs to be validated against manual counts. And same process for every reporting location. You want to make sure that your electronic counts are within plus or minus 5% of your manual counts for 3 consecutive months. And the reason we recommend this is because comparing a new electronic system to an existing electronic system can magnify any errors that are already present. And again, this validation only needs to be done once when you're transitioning. It doesn't have to be done every year. We also highly recommend that you conduct spot checks on your electronic systems to assure continued accurate data capture by these systems. For SSI denominator data, to ensure that your procedure data are not missed, you want to identify all potential data sources for capturing procedures by ICD-10, PCS, or CPT codes, such as your hospital discharge data. You also might want to cross-reference multiple sources of data so you can reduce your missing or over-reporting of procedures. For example, you can compare your OR procedure schedule with your discharge coding to ensure that you've got complete procedure capture. You will also want to perform spot checks to ensure complete procedure capture, especially if you're using an electronic system to upload your procedures. So I just heard from an IP from a facility that had an electronic system that uploaded the procedure data into NHSN, and the facility had never validated that the data that was uploaded was accurate. And 1 month, the IP went in to enter an SSI and wasn't able to link it to the procedure because the procedure wasn't in the system. So when they went back to investigate this, they found out that their electronic system was only programmed to capture procedures that occurred from the 1st through the 30th of the month. So any procedure that ever occurred on the 31st of the month was not in their system. And because they never looked at their data, they had to go back for about 2 years worth of data to fix that. So really important to make sure you know what's being uploaded and that you're checking your electronic data. Moving on to monthly recommendations. On a monthly basis, you want to ensure that you've correctly completed your monthly reporting plan, and Scott covered that pretty extensively. We also strongly encourage that you check the completeness and accuracy of your data on a routine monthly basis, and this way you'll be able to stay on top of your data and be more assured that you're maintaining your data accuracy. So examples of what to check for, I've listed some on the screen: missing data, implausible data, outliers that can result in data exclusion, incomplete or inaccurate data. And once again, can't emphasize enough to clear your outstanding NHSN alerts. If you don't clear these alerts, this data is not your data is not going to be completely accurate. That data won't be included in your SIR, and that data will not go to CMS. And somebody was asking about, how do I know what reports I can use to check what data? Well, we've put together some data quality checklists that are in the internal validation guidance document that we hope will be helpful to help you organize your monthly data checks. So these data quality checklists, we have 3 of them available. There's one for CAUTI-CLABSI, one for Lab ID, and one for SSI. And I've put in here a snapshot of the SSI checklist. And the checklists provide recommended data quality checks that you can do of common errors that we see for both numerator or event data and for your denominator data for each HAI type. And we also have included in there associated descriptions or actions of what you want to look for, and analysis reports that are available for checking this data and how to access those analysis reports. So as you can see here from the Lab ID event, a recommendation on how to verify your denominator accuracy for all reporting locations. And there's 3 different ways, or in 3 different reports you can access to verify this data. And we've given you instructions on how to access your data from 3 different methods. And in his presentation, Scott gave a lot of excellent overview of the analysis reports and how to modify them and customize them. And so we recommend that you use the information Scott provided in conjunction with these data quality checklists to customize your data validation plan. In addition to reviewing your data on a monthly basis, we also recommend that you review your data on a quarterly basis prior to your CMS submission deadlines to make sure that what you think is going to CMS is going to CMS. On a daily or weekly basis, we recommend that you conduct spot checks to track accurate denominator data collection and conduct active case finding, which includes reviewing your positive lab specimens and spot checking patient days, patient admissions, device days, procedure capture, and SSI risk adjustment variables to ensure that they're being entered accurately. In addition to the recommended routine data quality checks, what else should trigger your additional data quality checks? If you have new patient care locations added to your facility, you want to make sure to verify that they're correctly mapped. If you have new staff collecting data, you're going to want to verify that your staff understands how to do that correctly. And if you've implemented a new electronic medical record system or your current system has been updated, you want to validate that the new system against manual counts. As we all know, sometimes when you update systems, things get broken. So you definitely want to make sure you're verifying that things work the way you expect them to. And if you're seeing unusual data when you're running those reports, verify that your data was collected and entered correctly and completely. So we also have a few additional recommendations that you can do for internal data validation. Besides the annual monthly checks, we recommend that you conduct routine case ascertainment checks. I mentioned earlier, we also have that CDC external validation guidance and toolkit on our webpage, and it provides what we call medical record abstraction tools that you can use to verify that you are calling your cases correctly. And we have them for each HAI type: CAUTI-CLABSI, SSI, and Lab ID events. And you can use these to verify your ability to accurately determine cases. And we also recommend you consider doing this routinely with multiple reviewers to check inter-rater reliability. And when you find that cases are missed, you'll want to investigate why and determine how to correct the issue. Another feature of the analysis reports in NHSN is the ability to generate line lists and run charts for analysis and to assess patterns of errors. Longitudinal data can be run for numerators, denominators, and SIRs by location and overall, and Scott touched on some of these reports that you can run in his presentation. So I just wanted to give an example of how to assess longitudinal trends. This slide shows CLABSI events in an LTAC ward from January through December of 2017. And as you can see, it went from 10 events in January to 1 event in February. And then it went from 6 events in May to 13 events in June. And for these months, you had similar patient days and similar device days. So you want to make sure that you check to see if these declines and inclines are accurate or if there's something going on with your data. However, don't wait until after your CMS submission deadlines to run these longitudinal trends. You want to make sure you're doing this periodically along the way to make sure that your data is consistent and accurate and that you're identifying potential errors in plenty of time to correct them before your deadlines. So what can you do at a minimum at your facility to ensure that your data are complete? Some examples for completeness of numerator review or event review. CLABSI and CAUTI, you want to review every positive blood specimen and every urine culture as candidate events to rule out the possibility of missing a case. For potential SSIs, you want to identify and review all post-op patients and hospital readmissions. If you review just your wound cultures, you're probably going to miss about half of your potential SSIs. So you want to make sure you're doing those rounds in your units to identify potential infections. And for lab ID events, you want to assess and review all lab test results from inpatient, emergency, and observation locations since they're all included. Similarly, for denominator data completeness, you want to review the presence of central line or indwelling urinary catheters for every positive specimen or culture and ensure that collection of your device days is complete. For operative procedures that you're reporting, you want to ensure that you've gathered a complete count of all the procedures based on the ICD-10 PCS or the CPT codes. And when you're reporting your FACWIDE in lab ID denominators, you want to ensure that you have all patient admissions and encounters from every location accounted for. And you've also subtracted out your inpatient rehab facilities, your inpatient psychiatric facilities, and your NICU and well baby location counts appropriately. So it's important to have confidence in the quality of your facility's data. Routine internal data validation ensures that your facility is up to date with NHSN methods and surveillance definitions and that you are applying them correctly. In summary, quality data is vital to HII prevention, and ongoing internal data validation is key for improvement in prevention practices. Routine internal data validation also leads to improved results if your facility undergoes an external data validation. Thank you. Are there any questions? And that's my puppy when he graduated from puppy school.
Good morning. If you have an electronic medical record system that is communicating with NHSN, and you also have flags on patients and all of that in your medical record system, it's really got an IP kind of function. Do you have to look at every culture, every blood culture, some of us have hundreds. I'm saying hundreds. I hear thousands in the crowd.
You're going to want to spot check to make sure that things are being captured accurately. I remember from my experiences in IP, all of a sudden I realized I was missing lab results because my lab changed something in the way they were reported, so that information wasn't being transmitted. Because, computers, they get what they get, and if you do something different, the computer doesn't know to do something different unless you tell it to. So it's really important to keep spot checking all these electronic capture methods to make sure that they're consistently capturing what you think they're capturing.
Good morning. My name is Kim, and I'm from Beaumont Health. And I have a question in regards to what would your definition be for spot check?
It's going to be facility dependent. If you know that something's changed in your facility that can affect your data, then you're going to want to spot check it. If things are pretty consistent in your facility, you might not have to spot check as often. But if you suspect that you're seeing things in your data when you're running these data quality checks that are not kosher, then you're going to want to try to figure out what's going on and kind of spot check your procedures to make sure that you're getting what you think you're getting.
Thank you.
Okay, Jennifer, we have a couple questions from the web streamers. The first one is, isn't there a minimum number of denominator days, beds, ADC, or something else that would allow weekly sampling? I can't imagine very small numbers would be valid.
I don't think I caught all of that.
So the question is there a minimum number of denominator days or beds or something that would allow weekly sampling? I can't imagine very small numbers would be valid.
Kathy says it's 75. That's for a recommendation from the CLAB CCOTY chapters where you're going to be counting your denominator days.
75.
75 average. 75 average device days per month. Under that, you're going to want to do daily counts.
Okay, your next question is, I heard that the manual count is the gold standard for counting denominator days. I would disagree. When we transition from one electronic system to another electronic system, we found that there are more issues with the human error when counting manually. The electronic system was much more accurate. Please advise what to do in this case. Could you consider revising the handouts is the gold standard? Hand count.
I'm not surprised I got that question. This is something that we have had many questions about, and NHSN maintains that your manual device counting is supposed to be the accurate way to do it, knowing that you're counting every unit at the same time every day. So that really is our gold standard, and that's what we recommend you validate against. And if you find that your gold standard is not working properly, how do you know everything was validated right the first time? So we really do recommend that you validate against manual counts and work to get those manual counts accurate, and then validate against that. Any other questions? Thank you so much.